opens their mind to how the health sector actually runs. Because we are used to being in the ward and complaining that there are no gloves. But when you sit here and you hear CEC complain even louder than you about money, then you understand why you don't have gloves in the ward. So we are very happy to be part of this process. And that's just an introduction of who we are. As Dr. Bashir said, we are tired of sitting with families to tell them that your relative did not make it out of labor ward, or your sister died in theater, or your baby did not make it. We are tired. So we decided we are going to take this conversation to the people who make decisions, and that's why we are here. So we are just a voluntary group of people. We started in 5 counties of Murang'a, Kiambu, Nairobi, Machakos, Kajiado, and the 2 referral hospitals in that region to just amplify the voice of the frontline health worker. We have since grown. And I am very happy that after our last meeting, a few of you actually took up the responsibility of making sure that MPDSR is active in your counties. I want to mention Elgeyo Marakwet. We were sent a photo of you with your team. You actually went and met your consultants. Kericho, where is Kericho? Kericho is doing very well. Your director, after the meeting, went and sat with all the consultants in their county. We have Bungoma. Bungoma is also doing very, very well. Yeah, Dr. Felista is very loud, and she has said newborns must stop dying in Bungoma. So we are very happy that many of you actually took this up. Tharaka-Nithi, yes, Dr. Riara. They are on I think, their 4th week of MPDSR meeting. I know Kilifi is starting next week, and we are here to cheer you on. We are here to cheer you on. So we have been engaging with many of you, all those people that are listed there. We had a very successful side event, MPDSR side event at the Devolution Conference. It was very successful. The chair of the health committee actually committed to making sure that going forward, counties will actually set aside money for MNH. We say that in our budget, this percentage is going to go to reducing maternal and newborn mortality. It's not moving. Yes, so why inter-county, you may ask that question. Health is largely devolved, but patients will go wherever they want to go to seek services. I think we were sitting here and asking the question of ambulances. Why should a woman in Kajiado die? Because the ambulances there were all engaged, yet there's an idle ambulance in Machakos. And the difference between Machakos and Kajiado is a road. You get? Or you have blood. We are looking for blood group B positive, and we can't find it in Kiambu. And our neighbors in Murang'a probably have 20 pints of that blood. So that's why we decided we are going to start talking to each other. We have very many successful stories. I know I've shared some of them with you in the last meeting. I'll not go back into that discussion. But how do we share those very scarce resources, like ICU beds? A mother needs an ICU bed, and there's one in, say, Kajiado, and there's a patient in Kiambu who needs that bed. Why can't we take this woman there so that she can survive? So what is the problem we are trying to sort out? So what is the problem? Dr. Nyanjao gave us the numbers. So let me put the numbers in figures, in photos. We lose 5,000 women every year to pregnancy-related complications. Those are 15 fully loaded planes crashing every year. That's a plane every month carrying 340 women. So we have a plane crashing every month with 340 women, and on some months there are 2 of them. And we move on like nothing happened. When there was a plane crash, and may God rest their souls in peace, in Ethiopia, what did the manufacturer of the planes do? What did they do? A lot of things happened because one plane had crashed. But here we are, 15 planes full of 300 women, 40 women crashing every year, and our lives move on as if nothing happened. The story for newborns is even worse. Every day, say day, every day, we lose 92 newborns. People who have not started life are lost. That's like a jumbo jet crashing every day. Na tunaendelea tu hapa Mombasa. If one crashes, and God forbid, if one crashes now, even this meeting is going to stop. But we are here with 92 newborns every single day. The reason all of you are here is because you didn't die as newborns. Sindio? If you had died as a newborn, you wouldn't be here. You didn't die as newborns, and that is why you're in this meeting. Stop letting future governors and future presidents die. So it's as if a whole generation disappears. Every day, a whole generation gone before they even start their lives. And these are not just numbers as we've seen from the couple. So CEC is, if 5,000 maternal deaths annually, 33,000 neonatal deaths annually do not move you, then I don't know what will move you. You must be made of a heart of stone. But the story can change, all right? So we must stop this tragedy that is happening every day and ensure that babies are landing safely here and leaving their mothers alive. So I'll not go into the details of this except the very last one on the political leadership. How many of you log into your MPDSR meetings? How many of you participate? Thank you. Siaya, that's which county? Migori County. Thank you. As Dr. Bashir has said, we can review all the 5,000 maternal deaths and tick boxes and give the ministry a good report, give CoG a good report. That will not save anybody. What will save women and newborns is responding to the issues that are raised from those reviews. And you're the people who have the money. If we say the ambulance was not functional that day, it was not available, the nurse in the ward cannot fix the ambulance. So you must be actively engaged in MPDSR so that we can save mothers and newborns. So I want to ask Waziri wa Kajiado. I like him because when we talked in Naivasha, he went and implemented almost everything we agreed on, and Kajiado is doing very well. They have a team that is doing very well with MPDSR. The other time we were awake, you may not be aware, but we stay awake when any of the counties in our team is in a crisis, we stay awake. So we stayed awake to fix a referral from Ngong sub-county to Kajiado level 5, but we were trying to get a bed that was closer, an ICU bed maybe in Nairobi or Kiambu. We couldn't get one, but eventually she ended up in Kajiado and she's home raising her babies. So I want to ask you, when a mother dies while giving birth, let's say a mother dies on 5th of August and leaves a newborn, does that family celebrate the birthday of that baby on 5th of August, or do they hold a memorial for their mother? What do you think they should do? Is it a birthday for the baby because the baby is alive? Or is it a memorial for the loss of their mother? Think about it, all right? I have a lady who does my hair. And she told me her story one time, and she told me their mom died giving birth to their 11th born. And of course, the sister was taken over by the auntie. She's now in her 30s. And she told me it's only 10 years ago that they accepted that girl as their sibling because they looked at her as the person who caused the death of their mother for a very long time. So they never wanted to associate with her until just recently when they realized, you know, you could also die as a woman while giving birth. And she didn't choose to kill mom. But those are the long-term effects of a maternal or a newborn death. So let's think about it. You're all in positions of influence. And this was a quote that was given to us by my colleague. She's a physician. And she told us in a meeting with our governor, we had a meeting with our governor in June, on MPDSR, and she said, whether you're the governor, whether you're the lab tech, the director general, whoever you are, the ambulance driver, do not let your actions or inactions be the reason children place flowers on their mother's grave or a mother flowers on her newborn baby's grave. So that's my challenge to you in this room. We are there to support you as your frontline soldiers, because sisi ndio tuko kazi, sisi ndio tuko ground. So let us bridge the gap that exists, that very wide gap between the health managers in the county and ourselves. This is where I work. So this is proof that you can end maternal deaths. Kiambu Level 5 is the 5th busiest maternity in this country. This year, unfortunately, we lost a mother in August, but for 7 months, from January to 14th of August, we had not had a maternal death. We unfortunately had one on the night of 14th of August, who stayed with us for less than 30 minutes, and she came from actually another county. That's why we are insisting on inter-county collaboration. So if Kiambu County can do it, we deliver 7,000 women per year or more. If we can do it, everybody, every facility can do it. I will stop there because I get very emotional when I start talking about maternal deaths. So I will stop there and hand over. We have not finished. Our session is not over. So I will invite Dr. Grace Wanjiku to very quickly tell us the practical things we are asking of you so that we can save mothers. Not science, but this is what we want in labor ward so that mothers can stop dying. Then Dr. Manyasi will come very quickly and tell us what is it that we need to do to start saving our newborns. Thank you very much.
Thank you, Dr. Maina. My name is Dr. Grace Wanjiku. My presentation is very short because actually the problem with presenting after so many things have been said is that everything you wanted to say is usually said before you. So I work in Murang'a County. My station is Murang'a County Referral Hospital. I look forward to the day I will stand in front of a crowd like this and say, like Dr. Maina, I have not had maternal mortalities for the last 5 months. We look forward to that. So we know that the top 5 causes of maternal deaths in our country and actually world over. Postpartum hemorrhage, which is basically a mother bleeding after she has delivered. Hypertensive diseases of pregnancy, where because of the changes in pregnancy, the blood pressure goes up when a mother is pregnant. Sepsis, which is basically just overwhelming infection in the woman's body. Obstructed labor, this one is self-explanatory, and unsafe abortions, which is where a bit of the teenage mothers come in. So what are these things that we are asking for as obstetricians, as midwives, as medical officers in our facilities? It is basic things. Quality oxytocin, medicines that prevent our mothers from dying from excessive bleeding after they have delivered. Oxytocin, carbetocin, a drug called tranexamic acid, misoprostol. Those ones are the ones that we use mainly when we are dealing with excessive bleeding in pregnancy. Magnesium sulfate and antihypertensives are just basically drugs that we use to treat mothers who have an elevated blood pressure. The other thing that we are basically asking for, and before I move on from the medicines, is that these medicines are actually available. They're available in KEMSA. They're available at very affordable prices, and especially this drug called carbetocin that was recently introduced as a first line. First line it is recommended as a first drug that you can use to prevent excessive bleeding in pregnancy. It is currently available and at an affordable price, and this has been implemented in some counties like Makueni that have not had lost a mother for the last how long? 2 years, for the last 2 years, because of excessive bleeding, because of just introducing this drug and some other interventions that we will talk about. So it is an affordable drug, and the good thing with it, what separates it from the first one that we call oxytocin is the fact that oxytocin requires that you have working refrigerators. So the carbetocin removes that from you. So carbetocin, you can store it at room temperature and it will work effectively. The other one that we are asking for is something, simple technologies. There's something called calibrated V-drips. I will show them in the next slide. You can move on to the next slide, please. The next one. These are the drugs we talked about. This is a calibrated V-drip. And what we noticed, or what was noticed, is the fact that, especially when mothers deliver, after delivery, there is the normal or expected amount of blood loss that you expect them to lose after they have delivered. But we noticed that as healthcare workers, as midwives, as doctors, as obstetricians, it is very easy to underestimate the amount of blood that a mother loses after they have given birth. And by the time you're realizing that this mother is actually losing too much blood, then it becomes too late. So what this drip does, because it is just wrapped around the mother's buttocks, and it just collects the amount of blood that the mother is losing, and it allows you, it is calibrated, it has some numbers that probably you can't see down there. It allows you to know that at this point now, you're entering into the danger zone, that you need to start intervening. You remember those drugs I mentioned? The carbetocin, oxytocin, tranexamic acid, misoprostol. When given on time, when you combine this measurement of blood loss plus the drugs that I have mentioned, it has been shown that it reduces postpartum hemorrhage or excessive bleeding by almost 60%. That is research, and it was actually done in this country, okay? So those are some of the things that we are asking for. There is another very simple technology that has been introduced into the country. I know the Luala community is working on this in the country, and it is called an pneumatic anti-shock garment. Just going back to excessive bleeding in pregnancy, because what happens when a mother bleeds too much is that the body becomes overwhelmed because the oxygen is not circulating properly, her kidneys start failing, her liver starts failing, her heart gets overwhelmed, and then eventually her brain just dies because she's losing oxygen. So what this does, and it works very well, especially for lower level facilities, and even in higher level facilities, before a mother is moved from labor ward, where she delivered, to theater, she can be wrapped in this garment, and what it does is that it shunts blood from the non-vital areas, and it shunts them to the vital areas, the heart, the brain, the kidneys, and the lungs, so that you can maintain the life of that mother as she's moving from one point to another. It is a very effective intervention, and this would really, really work well for the level 2s and the level 3 and the level 4 facilities that are not able to have surgical interventions. And these things are not beyond, they are not beyond our capability, because there are counties that have these interventions, like the one I've mentioned in Makueni. I think even in Narok, they have the pneumatic anti-shock garment, and it is working very well for them. And we are encouraging our governments to actually be proactive in providing these facilities for the midwives and the doctors on the ground to be able to save our mothers. The NPDSR issue has been spoken about. Dr. Bashir has enumerated on it. We need to get champions and support for these champions on the ground, because not everybody is very interested. Everybody has their own interests. But if you can get people who can champion this process in your counties and actually support them through that process. And actually, as Dr. Maina was asking, please join those meetings. Just joining those meetings usually motivates your workers so much, because they know that their voices will be heard in these meetings. And actually, there's so much activity and so much response that comes from those meetings. Just by you joining and telling them, we have heard you, and we are going to work on these things, and actually working on them goes a long way to encourage them. The issue of human resource management has also been spoken about. The PS spoke about it. It has been spoken about from yesterday and even today. So we know that our midwife doctor-patient ratios are very bad, and we need to work on it as a government. And we know that it impacts on the quality of care. I will not go into those details because they have been spoken about. The issues of salaries, promotions, provision of medical covers for our healthcare workers, because you want this healthcare worker, whether it's a doctor, a medical officer, a nurse, a midwife, when they come to work, they're not thinking about, if my child gets sick, I do not have a cover. My salary has been delayed for the last 2-3 months. You know, I have not been promoted for the last 10 years. And you end up with a very demotivated worker. So those are some of the things that we are asking you to help us with, because we know you have a lot of influence in your local governments. And I will end with these 2 quotes. There is a very famous professor who was once the president of the International Federation of Obstetricians and Gynecologists, and he said that mothers are not dying from diseases that we cannot treat. They are dying because we are yet to make the decision as a society that their lives are worth saving. So if we make a decision as counties that in this county we are not going to lose mothers from preventable causes, it is possible to actually achieve that. And it's Mahatma Gandhi who said that the true measure of any society is in how it treats its most vulnerable members. The mothers who are pregnant, the mothers who have delivered, or the mothers who are in labor, and their newborn babies. How do we treat them as a society? Think about it. Thank you very much.
Dr. Manyasi is a neonatologist at Mbagathi. She keeps saying she's the only one in the room who speaks about the very little people who can't speak for themselves. So we'll give her 10 minutes maximum, Dr. Manyasi, and then you sit down, all right?
Thank you for the reminder. I tend to get carried away. I will try. I am the tall advocate for short people. So kindly allow me 10 minutes. And the choice of pause on the first slide. I'd like you to say that in a childlike voice, okay? Thank you. Imagine that voice as we have this conversation, and me, because that is what that little baby is asking you as a leader today. So I don't want to dwell on this slide. We've had a lot said. Only two highlights, that from a 50 million population and about 1 million births every year, this country has less than 50 neonatal ICU beds. And out of all those, 2 are in a county setup. Ngapi? 2. The rest are level 6. Please think about that. That statistic we were told is like getting the whole of Nyayo Stadium full and then bombing it per year for newborns. Or a Scania bus crashing every day on that highway. Those are the newborns we are sending to the morgue. So why are so many newborns dying? Either they are born wrong, and I'll say what that means. Either they are too small, they need support, or they are sick, or they are not properly formed. But they need not all die. They are born wrongly. Nothing wrong with them, but they're just born in a wrong manner. That the antenatal was not right, the labor was not right, and then when they landed, there was no one to rescue them, resuscitation. Or they were born at the wrong place. Would you imagine that? If only they were born at the right place, they would have survived. That's why we are losing a whole Nyayo Stadium per year. So I've mentioned we have less than 50 NICU beds in this country. But even before we talk ICU, because we have levels of care, how many newborn units do we have in this country? I really appreciate that we've done a lot in opening up delivery facilities. And every county has many, many units delivering mothers of their newborns. Except we forget that for every delivery, there's a baby we expect. And for every 100 babies delivered, about 5 need some help to transition. So when we set up maternity facilities, Waziris, let's remember that the end result of a pregnancy is a baby, and we plan for that baby. That means that every delivery unit kindly ensure has facilities to help the baby transition for the 5 out of 100 who will require support. And in these places, who is caring for the babies? It's not enough to say there's a nurse. What is a nurse's capability? Not everybody can take care of newborns. If you were to walk into a room and find 10 healthcare workers and tell them, I am assigning duties today, nani ataenda NBU, my colleagues will tell you that most of them will run in the opposite direction. Why? Because newborns are delicate, They require a lot of attention. They are labor intensive. And in any hospital you go to, you'll find those are some of the most stressed teams. Their workload per unit baby is high, yet we give them the fewest numbers. Do we have doctors? Are they trained? So are they available? Are they trained to provide these services? It makes me sad that there are some counties that do not even have a pediatrician. Allow me to politely mention some. Waziri Vihiga, hauna daktari hata mmoja wa watoto in your county. Waziri Kirinyaga, kindly, if you don't have a team leader, you do not have a team. Please make that team, kindly. And there are many others that rely on such a trim level of resource that it cannot make a difference. I'll not belabor that. Allow me to skip. So what treatment are the newborns getting? We know that majority of babies need essential care. But even when we say essential, many times it's not available. I wish I had the time to show the graphs for the country where we do essential newborn care, just keeping the baby warm, giving vitamin K, giving chlorhexidine. Some counties are not even achieving 50%. Resuscitation and stabilization. For those ones who have issues at birth, are we able to stabilize them? They are not getting it. Referral. It's sad that for a sick baby to get any level of care, they have to be moved. And yet you have 1 minute, 60 seconds to get the baby breathing and 1 hour to ensure they survive. So most babies miss that window. No wonder, once they arrive where they are going, many of them die or are already dead. Eh? And then there's discharge and follow-up care after advanced care. So what gaps do we have? And I just want to fast track that because I have mentioned a lot of that. So these are photos from this country. Okay. Is there a pointer? Sorry? I'm trying to get the pointer. Okay. So things don't just go wrong, eh? They start wrong. Picture yourself being born in that room. Eh? What are the odds you'll survive? You do feel like an accident, right? That the room has no facility. There's a window, wind blowing in, nowhere for the baby. Then, why is it zooming? Okay. So those are newborn services in our counties. Waziris. Those are newborn services in our counties. Eh? Just think about it. They start wrong. Once you land here, there's a high chance that you will not go past there. Okay, just advance for me. Okay, and then once they land there, if they're lucky enough, this is what they meet. A mask bigger than the head, eh? Because our commodities only factored in the adults, eh? Or prongs blocking the nose so that they can die faster. Or there's a whole bunch of them in one warmer. In that tiny room, in a corner, that is called a newborn unit. This is a reality. This is why we are having this. So that is the end result of a late referral, no ICU, no staff, no drugs, no commodities. You have dead or disabled families, dead or disabled babies, and broken families. So, what am I here to request you? This study told us and I think we've all seen this by now, that one nurse is taking care of over 20 babies. In fact, in some cases, it's 40 to 50 babies. There's not much they can do. And I'd like us to remember that students are not staff. Because in some of our counties, we are saying, Sikuna MTC, we deploy more. So now we're actually having a crisis in our units where we have so many students, no staff to teach them, and many babies. What's the result? Infections, no care, or dangerous care. Students are not staff. Let's observe how many numbers we are signing off from our offices, because they are signed off in the county, okay? These agreements are signed off in the county, and then they are deployed to the units. Newborn care is specialized. It's not any other care. Kindly, let's put resources there. Newborn care is specialized. Not everybody can take care of newborns. And not all staff can care for newborns. Huh? So how can you help us as I wind up? We've sung about HRH. Allow me to emphasize that we need to employ. There are two ways, no two ways about it. We need to deploy. We need to retain. The numbers must go up somehow. Whatever you can do from your end, kindly do it. Huh? Let not your action or inaction be the reason a mother lays flowers on a grave. Eh? Train. Skills acquisition is not automatic when it comes to newborns. Allow me to emphasize this. We have even had scholarships for organizations wishing to support scaling up newborn care, but our counties have refused to release staff. There's nothing as frustrating as doing the same thing every day and hoping for a change. Skills acquisition must be prioritized. And I do agree with the direction the ministry is taking. I applaud them for that we do not need workshops, we need skills labs. So let's embrace them. Kindly find a way to make those skills labs work so that staff can attain skills and retain skills, hopefully at their workstations. But before they do that, we will have to invest. If every county had TOTs, for instance, if every facility had trainers of trainers, you would not need to release any people to go for training. They would do it in-house. But we must be brave and set the ball rolling. Let us kindly collaborate with the ministry, release them when we need to release them. It's a little pain for a short while. Some CCs were really kind, and they've been releasing nurses to go for neonatal nursing. And some counties now have 2, 3, 4. But most counties still have 0. Same to neonatologists. Some counties bit the bullet and released 1 or 2 to go for training. Now they are reaping the results. Even if we equip NICUs, we will not change anything without the HR. Okay? Then MPDSR champions per county. Kindly, Waziris, sit on those MPDSR meetings. Drive the meetings. Let the team feel your presence. The mark of a head of family is that they will come home even if they didn't get anything out there. True or false? And they'll tell you, I tried and I didn't find, but you feel their warmth, you feel their presence. Please lead those MPDSR teams in the counties and talk about the newborns, because these are the vulnerable people among you. Finally, commodities and drugs. Newborns have unique needs. We cannot bundle them in the hospital package. We must be deliberate about procuring items for them. Most of our formularies do not have anything for the newborn. They are mistakes. We try to fit adult things on them, and that's why you see those pictures of adult commodities being used on the newborns. Kindly, in your procurement plans, ask those questions. Make sure things are purchased for the newborn. Budget security and legislation. I know that you represent us in the county assemblies. Kindly make this loud and clear. Thank you.
Thank you so much. As the chair comes, thank you for giving us an opportunity. We are your foot soldiers. Musitupige sana. Don't wait for things to go wrong for you to show up in our hospitals. Engage us continuously so that we can be giving you feedback on what is going wrong. Thank you very much.
Thank you very much. Before we formally appreciate this team, I would like them to come forward here with Dr. Bashir, Chair Dr. Ganda, Katra, with the champions. These champions, very, very, the people who are so passionate about women and newborns, so that we have a group photo. Where is our camera person?
So we want to teach you an anthem. I think the Ministry of Health told you about Iwene. So Iwene is a global call for ending preventable maternal and newborn deaths by 2030. So Iwene means every woman, every newborn, everywhere. So we want everybody in the room to say every woman, every newborn, everywhere. 1, 2, go. Every woman, every newborn, everywhere. Again. Every woman, every newborn, everywhere. Yes. Okay, we go. Every woman, every newborn, everywhere. Survive and thrive. Every woman, every newborn, everywhere should survive and thrive. Thank you, Mabel, for the reminder.
Thank you. This was a very good session. I would like to ask our Madam Pakler to appreciate this team in a very, very special way. This is a team of people who are very, very passionate about the work that they do. Thank you.
Thank you so much. Being a woman, being a mother, I felt all the doctors who were giving that presentation, and I could see your facial expression. Maybe it is common for pediatricians and neonatologists, because also in my county, the pediatrician I have, they also talk at a very low tone, but they are so passionate. They have attachment with the babies. Congratulations, you are God sent, and we are not taking you for granted. May God bless you. I felt how you were talking, and it was like, oh, so they are speaking on behalf of the voiceless. And today we are saying what? Every woman, that should be our motto from today onwards. Hiyo ni Sarova declaration, eh? We are going to do that back in our counties. And about the MPDSR meetings, I normally attend once in a while, but today I'm challenged. I'll be attending 3/4 of the week. So it should be take it home. Let us take it positively from our ladies. And because they are ladies, and I'm also a lady, I'm a woman, I'm also a champion. I remember when I got my firstborn, I also went through hell. And that was in Moi Teaching and Referral Hospital. You can imagine. Tell me a woman in the village. That is why I went back to school and I did anesthesia because of what women used to go through in my county. I said the men, when they are called to come and attend an emergency obstructed labor or even ruptured uterus, they take their sweet time. It was a motto. It was so challenging. Mpaka nikasema, come what may. What a man can do, a woman can do it better. And that is why I'm an anesthesiologist. Anyway, we thank God for that. Thank you. I was called to appreciate the ladies. I can say stories. You know, I'm a good storyteller. Okay, let us all be upstanding for the wonderful ladies in the house. We are very few, and especially the female side, very few. Anyway, Dr. Katra, we are here for a mission. So let us appreciate them. Tutawapigia makofi. We start with one finger, because when they are born, they are still very tiny. They grow up to when they are women and even future leaders. Okay, we start 1, 2, go. Start with 1, 2, 3, 4. They are now adults. Thank you so much. God bless you. Asanteni sana.
Thank you very much. I know we have just about 3 sessions, very, very brief sessions. So I propose that we go through these sessions, we finish, then we take tea, and then Director Katra will tell us the rest of what's happening the rest of the evening. So I can see already the presentation from the Control and Auditor General's office is up. Maybe we can have that one very, very fast, and then we move to the emergency care program. Thank you.
Thank you so much. Good afternoon or good evening, everyone. Are we ready to hear the audit findings? So my name is Dorcas Muli. I'm a Director of Audit in charge of health. I'll take you through the findings from 2023-2024 financial year. It's the current financial year that we audited. We've actually already received financial statements for 2024-2025 financial year, and we've actually started the audit. So we've already consolidated the report for 2023-2024 financial year. I know the copies were very few, but the CoG got a copy. The rest will be available online. So I'll be taking you through the findings for level 4 and level 5 hospitals. The consolidation includes level 6 hospitals. And I usually say you cannot take healthcare in isolation. So as you discuss healthcare related issues, it's always good to see what is happening in other healthcare sectors. You can look at the Ministry of Health, what is going on at the State Department of Medical Services, look at what is going on at the State Department of Public Health and Professional Standards, look at what is going on at KEMSA, look at what is going on at SHA, because everything affects every other thing. And I think it was good to hear the practical that was presented, because from audit we usually say for every mismanagement, it's a life that was not able to get care. When you see the lives lost, from an audit perspective, we look at it as when there is waste, when there is mismanagement. So I'll be very brief, sorry. So I'll go through the mandate of OAG. I know we keep talking about it, but I'll be very brief. Then I will also talk about the audit services and the structure, then cross-cutting audit issues from level 4 and level 5 hospitals, then conclusion and a way forward. So that is the accountability mechanism. We look at it from the perspective of the citizens and the legislature. The citizens we appoint the members of parliament and the people that represent us. Then the executive does the spending, then we audit and report. So it's a triangle. I don't need to go through it. So that is the mandate of the Auditor General. It's a constitutional office. Article 229 of the Constitution, it provides for the audit of financial statements, then compliance on lawfulness and accountability, value for money investigations, arbitration, special requests, then risk management, governance, and internal controls. I know you've had an opportunity to look at the financial statements. Every time we audit financial statements, we usually report on 3 components: the audit of the accounts, where the opinion comes from. Then we have compliance, and lawfulness. Then we also report on risk management, governance, and internal controls. So we usually say the ultimate mandate of the Office of the Auditor General is to influence the development of our nation and the delivery of quality and sustainable services to the people. The good thing, I have been in the health sector audit for more than 15 years. And I'm a trained health economist, and I always look at the cost effectiveness of the spending in the different sectors. That is our vision, making a difference in the lives and livelihoods of the Kenyan people. And our mission is audit services that impact on effective and sustainable service delivery. Our core values are there: integrity, credibility, relevance, accountability, and independence. That is the OAG structure, and I like showing the structure so that you see where the audit of healthcare is placed. We have the Auditor General at the top. Then we have 7 Deputy Auditor Generals. Most of them are under the Financial Audit Services. Financial Audit Services, there is the audit of the MDAs and the state-owned agencies. We have 13 sectors. Then we have 15 regional offices. Then we have the Specialized Audit Services, Performance Audit, Information Systems Forensic, Public Debt, Citizen Accountability, and Emerging Audit Issues. And currently we have the Public-Private Partnerships. Then we have the Corporate Services, that the internal support function within the organization, HR, Finance, Procurement, ICT, then other internal support components. Then we also have other services that support mostly the audit function. We have corporate planning and external liaison. We have professional practices, legislative relations, that's our legal department. We have quality assurance, then we have internal audit. We have an audit committee that provides oversight over the internal audit function and the internal control environment. It is not a legal requirement for the office to have an internal audit function, but it's the first time with the current Auditor General that she saw it was important to have an oversight component for the internal functioning of the organization. I wanted to go briefly through the sectors, but I don't have to read all of them. So we have health, labor, and social protection in one. Health is the 2 state departments, then the agencies under the 2 state departments. Then labor and social protection is labor, the State Department of Labor and Skills Development, then State Department of Social Protection and Senior Citizen Affairs. I talked about the 15 regional offices. I think I can't see from there. So we have, I think we seem to be concentrated in some of the areas. We have Kitale Regional Office, we have Eldoret Regional Office, Kakamega, Kericho, Kisumu, Homa Bay, Nakuru, Isiolo, Garissa, Nyeri, Embu, Nairobi. Nairobi Regional Office is based in Nairobi. Then we have Machakos, Kilifi, and Mombasa. For the upper areas, they are served from Garissa and from Isiolo. Then I like talking about the audit process because it impacts on the audit outcome. The audit process, you plan, you execute, you report, then we also do follow-up. I like showing the details because sometimes people complained about how the process was. We usually start by issuing a letter of understanding. And this is like the contract between the auditor and the auditee. Then after the letter of understanding, we usually hold an audit entrance meeting with management. An audit entrance meeting is mandatory and it's a requirement by the Public Audit Act. Then once we start doing the audit, we issue audit queries on a continuous basis. Like I can give an example, we've already received financial statements for 2024-2025 financial year, and we've already started issuing queries because most of the reports were done in a hurry. Some of them are not adding up, some of them are not making sense. So I don't wait for me to go to the client for the audit. I start issuing as early as possible so that they can start adjusting where possible. Then after the audit process, we usually hold an audit exit meeting, which is also mandatory and it's required by the law. The audit entrance meeting, the accounting officer is supposed to chair the meeting. It's mandatory for the accounting officer to be in the meeting. So for the counties, the governor must be there. Otherwise, the audit will not start. Then after the exit meeting, we issue a management letter After issuing the management letter, the law requires us to give 14 days. Once we get the response, then the Auditor General drafts a draft audit report. Then we also give some time for responses. Every issue that is cleared after the management letter does not get into the draft audit report. Once the draft audit report is done, the client is also given time to respond. Any issues that are cleared at that point, they don't get to the final audit report. After the draft audit report, the final audit report is drafted, issued to the client, to the National Treasury, and to the auditee, and also to other stakeholders. Then we usually have public hearings. Public hearings are the presentations in parliamentary committees and county committees. Then we follow up on implementation of audit recommendations. Follow-up is in two ways. Number one is the recommendations that were given by the Auditor General. Number two is follow-up of the recommendations given by the different committees. I've already talked about that. So the health sector has so many components. So we have the two state departments, then we have the agencies under the state departments. I don't need to go through them. Maybe I can just pause you look at them. I'm sure you're familiar with all of them. There are around 70 agencies under the Ministry of Health. Then for the hospitals, I will go into the details of the hospitals. Okay. So I'll go straight to the cross-cutting audit findings from the 2023-2024 financial year. And as I've said, we've already consolidated into a booklet. All the hospitals are here, the hospitals that presented their financial statements for audit. That's a summary of the submissions. For level 5, 18 hospitals submitted. There are 18 level 5 hospitals, 17 submitted, 1 did not submit. Kakamega, I don't know what happened. They had not submitted the financial statements for audit. They had arrears for a long time, but I know they've already submitted for the arrears. For level 4, there are 376, 230 submitted, 146 did not submit. So the number that did not submit is 147, 37%. This was an improvement from the previous year. So for the opinions from the audit of last year, only one hospital had a modified opinion. Unmodified opinion is a clean opinion. We used to call it unqualified. It's a clean opinion. The financial statements are in agreement with the supporting documents. They are well supported, and everything is working as it should. 210 level 4 had qualified opinion. Then 16 level 5. A total of 226, majority, that is 91%, had qualified opinions. Then adverse, we had 16 level 4, 1 level 5. Then a disclaimer, we had 3, and I'll be able to show you the details. For disclaimer, it's a report that it doesn't make a lot of sense. It's not aligned with the supporting documents. There's no evidence, the financial statements are not adding up, so the Auditor General is not able to give an opinion on the financial statements. And I'll give you the details of the 3 hospitals that had a disclaimer, and the one that had unmodified, the rest you'll get from the summary. So it's only Chepararia Sub-County Hospital that had an unmodified opinion. And they were the first one to submit financial statements. Do you want to clap for them? West Pokot. So they were the first one to submit, actually, even before the timelines when the financial statements are supposed to be submitted. They were audited and they got a clean opinion. Then we're saying the high number of qualified opinions reflect negatively on preparation of financial statements. Actually, most of the qualifications were because of preparation. The numbers are not making sense, they are not adding up, they are not supported. Everything to do with financial statements automatically gives a qualified opinion. Then the 3 county hospitals that had a disclaimer, I said a disclaimer is where the accounts do not make sense. I'm using layman's language. One is Ahero County Level 4 Hospital, Kitale County Referral Hospital, and Migosi Sub-County Hospital. So the next summary is on, and as I said, I'm only giving the cross-cutting issues. You'll find issues in the booklet that are not part of what I'm presenting. So the financial reporting matters, and I said this is what gives the opinion. Most of the financial statements that were qualified, these were the cross-cutting issues. 141 had inaccuracies in the financial statements. For example, you find a figure in the statement of financial position with a note that is not adding up. A figure can be 10 million, but when you go to the note, when you add, it's 8 million. So it's not linked properly. Then we had unsupported expenditures. And you find most of these expenditures are for the same period. Again, you don't lose documents within the same year. Our audits are up to date. We don't have arrears of unaudited numbers. Then unreconciled variances, the figures are there, but they are not reconciled. Then inaccuracies in cash and cash equivalents, similar to the unreconciled. Whatever is in the financial statements does not agree with the cash and bank and the reconciliations thereof. Then revenue management, we had 35 hospitals that did not disclose the budgeted on revenues in the financial statements. So under the budgeting stage, it's like the own revenue was not budgeted for. So you only have what was collected at the end of the period. So this speaks to the budgeting process for the hospitals. Then 33 hospitals did not disclose the actual revenue they generated during the year. So when you go to the bank statements and to the cash book, there's actually revenue that was collected. But in the financial statement, it is not reported. Then failure to transfer revenues to the CRF account. That's around 755 million. That is for 19 hospitals. Then unaccounted revenue, 6 hospitals had unaccounted revenue of 214 million. Then uncollected revenue, we split it into two. One is receivables from non-exchange transaction. This is what is receivable from the government that you had budgeted for and you expected to receive in the course of the year. Then the other one is receivables from exchange transactions. Exchange transaction is where you're rendering services. So whatever you're expecting to receive. So we had a total of, for level 4 hospitals, 2.8 billion. For level 5 hospitals, it was 2.6 billion, a total of 5.4 billion. I don't know whether it is receivable, it will be received, or it will not be received, and especially from the non-exchange transactions. Then uncollected revenue, that is the total that I was talking about for both, for rendering of services and from the government, a total of 5.4 billion, 220 hospitals. So we call it uncollected revenue. Then other exceptions on revenue amounting to 5.9 billion in 82 hospitals were reported under, those are the exception, undisclosed from exchange and non-exchange, and I've already talked about that, unsupported revenue. Then those are the weaknesses in asset management. The blue one is level 4, the red one is level 5, the green one is level 6. So for the level 4 hospitals, undisclosed property, plant, and equipment for 122 hospitals. Most of it is motor vehicles, land, and other fixed assets. Then lack of ownership documents, again, affected mostly the level 4 hospitals, and majority of it was land. No ownership documents for land. Then idle assets that are not in use, and also equipment. You have equipment in the hospitals, but they are not being utilized. And then the last one is on the stalled projects. And you'll be able to see the list of the stalled projects in the different hospitals, like the Kisii Cancer Center and other hospitals where there are stalled projects. Then internal controls, lack of updated assets registers, and we usually see when the asset register is not available and updated, most of the assets will grow legs, they will disappear from the facilities. Then lack of audit committee, and most of the time, you may not need to have an audit committee specifically for the hospitals. The counties can get a way of using the county audit committee to provide oversight over the different hospitals. Then again, lack of internal audit function. You may not afford to have an internal auditor for every hospital, but is there evidence of internal audit function? This can be from the county. Then stores management, poor stores management. Then the last one is inadequate controls in revenue collection systems in terms of recording. Some of them are manual, so you're not able to confirm the completeness of the revenue. Then the last part is on governance-related issues. Ineffective governance by boards of management. Some of the board members, their contracts have expired, others are not well appointed. Then again, irregular composition of the board. Then lack of policy documents and operating manuals. Then non-compliance with the Public Sector Accounting Standards Board reporting framework. So the reporting framework is very simple and straightforward, but you'll find hospitals that are not using the template for reporting. And this again contributes to the qualification because of how the financial statements have been prepared. So that was the last one. So what is our commitment is to support county governments to safeguard public funds. We need to adopt audit readiness principles, proactively prepare for upcoming audits. Then we need to act on audit recommendations that have been raised in the past. Thank you very much.
Thank you very much for that presentation. This is a slight deviation from what we've been discussing. Maybe there are one or two questions for her before she leaves the stage. Yes, you have a question? Or we do one plenary at the end. Okay, which means, okay, so we've agreed on one plenary at the end so that we save on time. So thank you very much. Maybe we need to appreciate her a little bit better. Who is the expert, the assistant, to appreciate her before we... No, the assistant this time. Thank you.
Yeah, while you were away, in the 2023-24 financial year hospital audits, only one hospital happens to have gotten a modified report, and it is Chepareria Hospital. So how do we do that one for her? Because yeah, I think we will combine. We'll combine these three and then three down. Sawa. So for Waziri West Pokot, 1, 2, 3, go. Again. That's enough. Asante. We have the auditor with the OEG, the office of the OEG, with a very good report. And although we require more details on that. And nobody said something about chairman. Did you see chairman's hospital somewhere? But he's very silent, eh? So let's appreciate the OAG, the lady there. We are going to do Kanu 3. We are going to do Kanu 3. 1, 2, Funga, Fungua.
Thank you very much. One of our partners, we've been working in several counties and also supporting this meeting, is Luala. So I would like to welcome Luala. He'll introduce himself and just briefly talk about what Luala does. Thank you.
Thank you very much, Waziri. Good evening, or good afternoon. Actually, it's good evening. Okay, so Ms. Katra, did you want us to have an energizer before I go on? Or the energizer was... Very well said. So my name is Kenneth Ogendo. I work for Luala and I lead policy, advocacy, and partnerships. And indeed, I'm very glad to be in this forum. And we have partnered with the Council of Governors as well as the MPDSR initiative and a host of other county governments that are in the room. And we are really very honored to be given the chance to make a presentation in this meeting. I will be going straight to the point, and I just want to underscore the great imagery by Dr. Maina and her team, painting to us the picture of the maternal mortality indicators in this country. And you have humanized that story by bringing a couple over here, because most of the times we get systematically desensitized from statistics. And we look at people as numbers. But now we are humanizing this data. And as Luala, we are keen to notice that every 2 minutes, we lose a woman due to preventable deaths globally. Every 2 hours, we lose a woman in this country. And yet 70% of these deaths are preventable. So as Luala, we are on a mission to reduce maternal mortality and child mortalities as well as morbidities. I would like to go on to my first slide, and hoping that by the end of this conversation, we shall move towards supporting the national government and the county governments to get into the SDG at, losing 70 mothers per 100,000 live births. That's the vision. And also we are looking to support the county governments as well to reduce the neonatal deaths from 21 per 1,000 live births to 12 deaths per 1,000 live births by the year 2030. So here is to my first slide on Luala, and I will just briefly say that Luala began as an idea by these two doctors, and we have doctors in the room. So many Lualas are possible. And Luala is bringing in a lot of resources to this country to support and catalyze domestic financing and reduce maternal mortality, and as well as neonatal mortality, and also child mortality. I would like to say that these gentlemen were taken to school by the community, and they sold cows and goats, and their parents actually died to HIV. And they are now in the US, they're still alive. They are, pediatrician and cardiologists in the US, but they are still very keen to support this country. But I would like you to see that we have communities that came up together to donate land and donate resources for them to go and study, and they came back to give back. So we are on a mission to unlock the potential of communities to advance their own health, and we believe in the mantra of health promotion that communities should actually take charge of their own health. And our vision is that when communities lead, change is lasting. I also want to say that we're on a mission to transform health by centering communities at the center of the conversation and the center of the health system. And we believe in changing systems, and that's why we are keen to support the Council of Governors as well as support the national government. So I will skip these statistics because we have gotten great descriptions about them. We are where we're losing 5,000 women annually. And I want to underscore why Luala supports a few counties. And if you look at this schematic, we are very keen to support Homa Bay, and we are proudly associated with the indicators in Homa Bay right now. We are told over the last 100 days about there, they have not had any maternal deaths as a result of postpartum hemorrhage. And we also want to see the same happening in other counties. We work very closely with Migori, and we are happy that the CEC is in the room, and we have partnered together to support the systems in Homa Bay County, including saturating Migori County with NASG. Again, I would like you to see that we are also supporting Baringo. And Baringo does not have a high maternal burden as the other counties, but we are partnering with them together with Dandelion to also support the health systems thinking in that county. We are scouting for 2 more counties this year, and that's why I came to this meeting, and I hope to be speaking to the CECs. We are in 3 counties right now where we are doing what we call the community-led model, and we support the supply side and the demand side end to end. So our model is broad and also deep. And if you want to compare our model with other organizations, you would say that somebody might ask you, why are you not everywhere in the whole country? When you go to Migori County, we go broad and we go deep. And that's why we've been in Migori for many, many years. And we want to replicate our model in Homa Bay County. We go broad and we also go deep. We are also doing the same in partnership with Dandelion Africa in Baringo. We go broad and deep. And that is the beauty of our model, which I want to unpack for you in the next few minutes. And I know you want to go for tea, but I want to rush very quickly. I would like to say we're also keen on under 5 mortality, and you can see Migori is leading, followed by Siaya. So Siaya is a very big candidate for our model because we want to reduce these deaths. And again, we are supporting Baringo County. You can see their their mortality, under 5 mortality is at 55, also top 10 in the country. And we hope to partner with other county governments and other partners who want to reduce these deaths. And again, I will not belabor on the neonatal mortality. It has been well handled by the MPDSR initiative. I want to say that the problem that causes Loala to be where it is now, why we are existing, we look at our problem from 3 lenses. And the first one is community. And we have seen that, just like P.S. Toluga mentioned, we have so many teenage pregnancies. We have delayed health-seeking behaviors. We have long distances to facilities. I believe if you have the CEC Isiolo, the average distance, last time I checked, from a household to a health facility is 42 kilometers. Literally, a woman who is pregnant has to walk a marathon to get services. So we are trying to sensitize our governments, and that's why we are here, to tell us we need to reduce this problem by embracing community health workers. Again, looking at community health systems, we agree that they are underfunded. And we appreciate the funding so far. But what else can we do through SHA and FIF and other resources that are coming over? And yes, we have been having challenges on top-down approaches towards policy. We hope to work with you to continue the narrative of, bottom-up in terms of policy advocacy and formulation. So Loala's policy, or rather Loala's approach, is defined in those three pillars. The first one is anchored on professional community health workers. We believe we cannot make any change without professionalizing community health workers. And making them professional means they need to be digitized, they need to be trained, they need to be supervised, they need to be kitted, and they also need to be paid. And we are happy that the government of Kenya has actually entered into an intergovernmental partnership agreement with the counties, and we are now seeing for the first time since Alma Ata 1978, we are seeing them being paid. And we hope to continue supporting the professionalization journey of community health workers. Again, Loala's model is anchored on facilities, and you can see the beige schematic there, standing in for health facilities. We believe you cannot support communities without strengthening the health facility. And we push for quality improvement, work improvement teams. We push for quality improvement teams and quality improvement plans at the health facility level. And next to that diagram, we also have community committees. And we believe in social accountability. The community health committees breed social accountability. And the health facility management committees too breed social accountability. So if you strengthen the governance arm at the health facility and the governance arm at the community level, then you're able to strengthen governance in its entirety, and hence keeping the health system accountable. And this is the missing link, ladies and gentlemen, in all our healthcare discussions. We complain about budgets, but whenever we don't involve the community, the mzee wa kijiji, Mama Wamboga, into the conversation, very difficult for politicians and legislators to increase budgets to what we are crying about. It is high time, ladies and gentlemen, we need to stop preaching to the choir. The choir is we who are doctors, nurses, public health, and everybody who understands health. But now we need to, and that's why we are here, to talk to waziris like you, because you have access to the governors, you have access to the president, and we move these conversations. We believe in this model that is anchored by data and policy advocacy at the periphery, because without policy and advocacy empowering by data, then we cannot achieve anything. In short, the theory of change is if you have community health workers, quality health facilities, quality governance systems, then you can reduce maternal health and child health. I would like to skip this because I know time is moving, and basically these slides are just showing what we are doing in the event we come to your county, because we are scouting for 2 more counties. We're in Migori, Homa Bay, and Baringo. We do not know the other 2 counties, but I want to talk to CECs within the room and know where else we can go. If we come to your county to do the community-led model, we shall engage communities together with you to ensure that household visits are there, dialogue days are done, community action days are done, outreaches are done, and also scorecards are discussed. And again, at the CHC level, we also want to support the scorecard discussions and oversight and bringing in accountability. And lastly, we shall also support supervision at the community health level. And again, when you go to the facility, we shall work. Right now, we are training the Health Facility Management Committee members in Homa Bay County and Migori County in conjunction with the government there. And we have seen that this is the thing that we need to strengthen, because right now, I don't know how it is in your facilities, in your counties, you'll notice that thanks to FIF, we have more money at the health facilities. But how strong are the health facility management committees to absorb the money? Have you heard of some stories where they receive money and put up a gate instead of buying oxytocin or supplies? So we need to strengthen the governance system, and as well as capacity building on the healthcare workers, improving supply chain mechanisms, and diagnostics. I want to, again, jump quickly. I will not talk about evidence of impact because we approved our model to support governments and reduce mortalities and morbidities because people become more effective. As you see in Migori, when you go to Migori, maternal mortality was at 673. And right now it is at 412. And we are already seeing what's happening in Homa Bay together with Gladys Wanga, 100 days, no deaths. So we want to continue, due to postpartum hemorrhage, just to be precise. So we want to work together with you to reduce that. So we're in these counties, we are reaching 2.8 million people right now, and we want to spread the community-led model. We also are very keen on I think you can, I don't know if you can see at the back, but I've just mentioned you're going to 2 more counties. By the end of this year, you need to sign 2 more MOUs, and thanking Katra and Elijah who are supporting us in that scoping. And also, we are keen on emergency obstetric and newborn care, and hence that's why we supported you, Dr. Maina, because we see when government is at the front, we partners sit at the back. And for me, it is music when I see the doctors and the nurses and even the traditional birth attendants coming into these conversations because it's happening. And also we are keen on advocacy. And we have 2 major global coalitions that we have been able to co-convene and co-found. We have the CHU for UHC partnership that has led to many tangible outcomes in Kenya, like legislation and digitization through ECHIS, and Loala is a co-convener together with AMREF, and globally we work together with the Community Health Impact Coalition, which is pushing for salaried community health workers across board. And in the PPH front, we are working together with the PPH Secretariat to advance this discussion. So I want to draw your attention to this slide. And we are targeting discussions with all these counties, and I'll be reaching out to you. And if you are in the room, let us have a cup of tea today, in the evening, and even tomorrow. We hope to work with, so we already, in Migori, Homa Bay, and Baringo, we have MOUs there. We have an MOU in Garissa. Narok, we seek to have an MOU with you of reducing maternal mortality, if possible. Even if you are ready, we can send an MOU today because you're top 15 according to the Kenya National Bureau of Statistics, the census 2019. If you are here, I can put money on the table. We talk, we sign an MOU, and we start working together in Narok County. Again, Kajiado, thank you to CEC. We were able to sign something, and we are working together with you and Dr. Lydia, and we are happy that even Kajiado is taking upon MPDSR initiatives and NASGs. Kajiado actually bought 21 NASGs, and we doubled it. we are keen to go to Trans Nzoia and Siaya, as well as Espokot. Paclea, thank you for hosting us in your county. We are looking forward to you and Dr. Ruto, and hoping that if you buy 50 or 100, we promise you we shall give you another 100. So it's up to you to make a choice. And we're also keen to talk to Nyamira County if you're in the room. So we have other counties that are not necessarily having high burden, high maternal mortality, but they want to see NASG in their facilities. Some of them are like Mombasa, Kisii, Kitui, and Kilifi. And our MC, we had a conversation over lunch hour. We are ready when you are. And also we are targeting Narok, Bomet, Isiolo 2026. We are in conversations with these counties, and I'm looking for you, Narok, Bomet, Isiolo, Kericho. We are ready to sign an MOU. Even if you came right now, we just print it and sign, and we start the work. So this is the NASG situation in the country for the top 15 counties, and we have committed, as Luala, if you look at the middle column, we shall double. We have 3,844 NASGs required in all those counties. We are ready to purchase 1,922. Kama mnapiga makofi mnapiga vizuri. Nataka nimalize. I will not belabor. I think the only thing I can say here is that Luala is advocating for NASG to be part of, or rather to be incorporated in the KEMSA supply chain. And we are working in conjunction with Clinton Health Initiative. We want to see it that it is regularized and it's part of the health system. And thanks to Dr. Grace, she already showed you how NASG looks like. So that is the garment that was borrowed from NASA, the astronauts in the US, handed down to the military. It was, a very good innovation that has now been brought from war into the labor room where we still have a lot of war saving lives. I would like to say that Luala is keen to advocate for counties to purchase NASG through FIF and local budgets. And Kakamega County was able to raise money through FIF, and we are seeing a lot of opportunity in FIF. If you agree, we can work together. I would like to jump that slide and mention that we would really want to advocate for social health insurance registration, and we are supporting CHPs to mobilize because we are seeing the intersection between SHA and FIF and saturating NASG and EMONG across counties. I would also want to say one more thing on traditional birth attendants. And Katra, you remember last time in the devolution conference, we had a traditional birth attendant who came over, and she's been transformed to a community health worker. She has actually gone ahead to become a midwife. And we are asking the CECs to help us have a policy that allows the traditional birth attendants to be transformed as per the World Health Organization standards and guidelines. Are we aware that 10% of our deliveries are actually happening at home right now? We are aware about that. So our policy advancement as Luala, we are asking you and beseeching you as CECs to help us push for this position. We also are asking you as CECs to push for the position of community health committees, because they breed social accountability. And they'll help us resource mobilize. They'll talk to the MCAs and all the people on the ground. I would like to end by saying that there are a few things we see within the health system, and because you are the waziris, I would like to leave this on your table. We support PHC regulations. We are supporting the restoration of the mandates. You are aware that community health workers actually support the reduction of childhood illnesses such as pneumonia, malaria, and diarrhea. And the ICCM mandate was removed from the purview of community health workers. So it's upon us to restore this mandate. And I'm asking you, would you help us to change this narrative? The Primary Health Care Act, which brought in the payment of community health workers, which you're happy about. But again, on the other hand, they only say that they can only do first aid. And yet WHO and UNICEF have empirically told us it is possible to have community health workers do ICCM, integrated community case management. So would we support that? That's up to you, and I would ask CoG in your report, would you have a statement from the CECs? Again, I'm asking you, waziri wenzangu. Mimi sio waziri lakini wenzangu. Can community health units be recognized as spending units as per SHA? We are aware that SHA purchases strategic services at level 4, 3, and 2. But are you aware we cannot purchase services at level 1 from SHA? Yet, who is doing the registration? The community health workers. So this is a systemic, structural, and legal issue. But you are the lawmakers. You are the influencers. Would we ask, and today I was happy that P.S. Oluga mentioned that, we need to connect, we need to bring about the public health impact. So the question to us here is, would we allow CHUs, community health units, to be spending units so that SHIF can also purchase that service and have FIF monies being ring-fenced for level 1 as well? Because you're retaining all the monies at level 2, 3. How is level 1 doing? And level 1 is the way to get to the last mile. And I'm happy Dr. Ganda has been a big champion for community health workers in Kisumu County, and you being here, we hope we can have CHUs as spending units. And of course, we can put the structures around the PSC regulations. I want to say the last thing. We have this call to action. Katra, you can guide me. We had agreed at the devolution conference that the call to actions, which we co-developed with the MPDSR initiative, were to be given to the county governments for adoption. And we would not want to lose that conversation. So Katra, I heard them. Can I read them for the CECs to know, or what do you think?
Thank you so much. I think it is something that we missed out during devolution conference. I think, Ganda, I gave it to you to also give your input. Because the PS has just come back, I think we can quickly look at it, and then as we have the next presentation, they can print out, then Ganda, you sign with the PS. If you allow that. So it is just this one, it's up to number 5. I can read them. But there is another one. There are 11. There are 11. There are 2 slides. 2 slides. Can give me 2 minutes. Can we do that? Yes. Yeah, this is the thing that touches us, so we do it. Because we don't have any other presentation apart from the dinner presentation. PS amerudi, so Ganda na PS munasani.
Okay. So, this was the call to action. Okay. As I caucus there, I can bring you to speed. So we agreed at the devolution conference that we shall commit to activate and fully operationalize MPDSR committees at all levels in all 47 counties. Is that something doable, Waziri? Yes. That's number 1. Number 2, we shall turn death recommendations into life-saving actions. The recommendations that come from those committees. Is that agreeable? Fellow CECs, we also agreed that we shall allocate dedicated county budgets for maternal and newborn health. Agreeable? You have no choice. Very well. We agreed. And again, we commit to ensure immediate adoption and sustained supply of low-cost, high-impact interventions in all counties. I will not read all of them, but they were well mentioned by Dr. Grace. We have the Cabetocin, the calibrated drapes. We have all these are important, including CPAP and caffeine citrate for newborns. Are we agreeing that we shall support this? Are we agreeing? Waziri, tunakutegemea. Again, okay. Then the 5th one, we shall enhance human resources for health. That is a loaded statement, but has been well unpacked by presenters here and there. Have you taken the photo? And then I move on to the next one. Okay? All right. Number 6, we agreed we shall fully operationalize primary healthcare networks by expanding and empowering community health promoters to identify risky early and refer mothers to identify risks early and refer mothers and newborns promptly. We agree? All of those who agree say aye. Aye. Very well. Again, we agreed to champion public accountability forums. Do we agree? These are the health facility management committees, the CHCs, the dialogue days, every forum that allows even the, verbal autopsy. Again, we agreed to rapid translation of policy into action by aligning national and county policies and guidelines. That's number 8. Is it agreeable? Number 9, establish functional referral and transport systems. Is it agreeable? Number 10, integration of the electronic community health information system and EMRs in every county to ensure that no mother is lost in the continuum of care. Agreeable? And lastly, to engage in peer-to-peer learning from counties. Is it agreeable? You can take a picture there. And I would like to end with one quote, because we've talked a lot about mothers and children, and we as men, and I can see we have many men in the room, and men need to be committed to these conversations as well. And my question is, how many of us were in the labor ward when our wives were giving birth? Hands up. The men. Who stood in the labor room? Who stood there? Oh, at least we have 2 men. The other men are the ones who went and asked, amejifungua? Wacha nikuje. My wife challenged me to go to the labor room. Yes, Grace? Yeah? I move back? Yes, so I wanted to challenge the men in the room, and because we are on, and also to all the CCs here. There was a quote by Martin Luther King Jr., and this is my last statement. The ultimate measure of a man is not where he stands in moments of convenience and comfort, but where he stands in moments of challenges and controversy. And that marries very well with one of the quotes that was mentioned here, that the true test of a community or society is how we respond to the most vulnerable. So ending with the words of Grace and Manyasi, thinking about how we were watching Chan the other day. Can you imagine that whole stadium going with newborns or the planes? Let us not look at it as a small thing, but let us carry these things with heart. Thank you so much, and I look forward to more conversations. And back to you, Katra.
I think we need a better applause. Can we give him another round of claps for this very good presentation? And what is important is the challenge and the commitment that Luala is making in this. And thank you very much for the support that you have provided so far and the continued support that you're committing to this issue of ending maternal deaths in this country. I want to ask Madam Park-Claire to give us an exercise, something so that we have our last presentation. Before that, so we need an energizer. We've sat for too long. An energizer before the last presentation, please.
Did you go to Sunday school? Can we go back to where we started? Ama hiyo ni ngumu? Okay, let us sing. Of course, karibu PS. We are going to do a very short exercise. We need to sing, Remember those days you were in Sunday school. Okay, we start from head, shoulders. Yeah, next time I'll give you a Pokot song, you'll dance. And my sister from Elgeyo Marakwet will join me. Yeah. So head, shoulders, knees and toes, knees and toes, knees and... Do you know where the knees are? I'm not seeing Mawaziri Kilifi. Where is your knee? Okay. Okay, we can start, Okay. Head, shoulders, knees and toes, knees and toes, knees and toes. Head, shoulders, knees and toes, highs. So you are very good in Sunday school. Okay, now that the PS is around, I want the men to produce that bass, then the ladies the soprano. So tutasema, thank you, okay. So 1, 2, 3, of course the female will start. We say thank you, then the men, thank you. The last one, all of us. Okay, 1, 2, go. Ladies? 1, 2, 3. 1, 2, 3. 1, 2, 3. All of us, 1, 2, 3. Thank you. God bless you.
Thank you very much, Parkleya, for waking us up. Now we are on our final stretch, our last presentation of the day. Emergency Medicine Care Foundation, Kenya Foundation. Let's hear what they have for us as counties. Welcome.
With the 47 counties. But first of all, I need to find Dr. Ganda. Dr. Ganda, I need to find you. Everyone has been telling me they're looking forward to the E+ dinner. We are not E+. Yes? We are not E+. So 1,000 bob, please. Cash. Cash. So as the Emergency Medicine Kenya Foundation, we support governments to strengthen the emergency healthcare systems. We've worked with all of you. Yes? More or less. Just 1 or 2 new faces. Yeah? We do this through advocacy. Advocacy, we look at policies and frameworks. Watu wa Mombasa in the room, mnajiona? So Mombasa is one of the first counties to have actually completed the Emergency Medical Care Plan and the Emergency Medical Services Plan. These are derived from the national government emergency medical care policy. How many of you knew the national government has an emergency care policy? Do I take the quiet in the room as unknown? You talked about it in the morning. So they're letting you down today. The other is knowledge development. So from our mapping, we have around 265 public health facilities that meet the WHO guidelines.